Hello, this is Corliss.
Hi, Corliss. We're going to give everybody just another minute or so to join in. So it looks like we have 46 attendees already logged in, and then we'll get going.
All right. This is April. I can't see the slides. Did you start broadcasting yet?
She just pulled them up. You should be able to see them now.
Okay.
Can you see them?
That's popped up. I can see them. Thank you.
Okay, great. So hi, everyone. If you are just joining us, we are going to get started in just a moment. Give everybody just a little bit of time to get going. Your lines have been muted so that the presenters are able to speak, but we'll give you a quick run through of how to interact with your fellow participants over the text chat in just a moment. Hi, everybody. We want to welcome you to the Dissemination of Evidence-Informed Interventions webinar. My name is Alexis Marbach from the Dissemination of Evidence-Informed Interventions Dissemination and Evaluation Center, which is a mouthful, but we'll be introducing our whole team in just a moment. Just want to give everybody a quick run through of how to navigate Zoom webinar if you haven't participated in a Zoom webinar before. We've gone ahead and muted everybody so that we can reduce some of the background noise, so feel free to eat your lunch as you join in. And we are encouraging everybody to interact with us over the Zoom group chat. So we will have some of our colleagues who are working on this initiative speaking in the Zoom chat, and then we'll be able to share links with each other. So that's the best place to let us know if you're having problems with Zoom webinar, if any technical issues come up, or if you have questions for any of the presenters. If you haven't found the chat function yet, if you hover your mouse over the bottom of the Zoom screen, a black bar will appear, and there'll be a little icon that says chat. If you go ahead and click on that, Zoom group chat will appear on the right of your screen or browser. And then you'll notice that there's a little to box, and you can let us know that you want to send the message to everyone. So everyone on the webinar will be able to see the question that you have. I also want to let you know that we are recording Zoom webinar today, and we're recording that so that if anybody can't participate with us live today, they'll be able to go back to these slides. They'll be posted on the Target Center in the coming weeks, so stay tuned for more information on when those will be posted, and we will share the link to where they will be posted later in the presentation. So now I'd like to turn this over to April Stubbs-Smith, who's going to give us a welcome from HRSA.
Thank you, Alexis. Can you, next slide, please? Good afternoon, everyone. My name is April Stubbs-Smith. I am the director for the Domestic HIV Programs Division here in the HIV/AIDS Bureau's Office of Training and Capacity Development. And within our division, we have oversight of the Special Projects of National Significance, the SPINS program, the AIDS Education and Training Center program, the AETCs, as well as the Bureau's hepatitis programming, which is a part of SPINS. So I'd like to start off with our overall vision of HRSA. It is healthy communities, healthy people, and its mission is to improve and achieve health equity through access to quality services, a skilled health workforce, and innovative programs. And this really aligns with the HRSA HIV/AIDS Bureau vision, which is optimal HIV/AIDS care and treatment for all. Our mission here in HAB is to provide leadership and resources to assure access to and retention in high quality, integrated care and treatment services for vulnerable people living with HIV and their families. And this particular project supports HAB's mission through the investment of federal funds and activities designed to improve the systems of HIV care for people living with HIV/AIDS. Next slide. So in looking at the Dissemination of Evidence-Informed Interventions project, this project highlights the importance of implementing evidence-informed interventions that were adapted from previous SPINS initiatives. The project was funded in 2015 by HRSA, and again, it's a part of our SPINS program. And the goal is to study the implementation of 4 previously evidence-informed SPINS and Secretary's Minority AIDS Initiative funds, affectionately called SMAE funded interventions. This project is really exciting because it followed a rigorous implementation science approach and placed emphasis on evaluation of the implementation process throughout the project and cost analyses of these interventions. The goal of really to improving the continuum of care, outcomes of linkages, retention, re-engagement, and viral suppression among the client population. Next slide. And here's our leadership for this DEII project. Our office director in the Office of Training and Capacity Development is Harold Phillips. The director of the Office of Training and Capacity Development, myself, April, the director of Division of Domestic Programs, and our SPINS branch, our Demonstration and Evaluation branch, is led by Adon Kahina, who's the branch chief, and the project officer for the DEII specific project is Dr. Corley Tees, who's the health scientist on this project. Next slide. With that, I'll turn it over to Sally Bachman to welcome the DEII Dissemination Evaluation Center. Sally?
Thank you, April. We appreciate you kicking off this webinar for us and your leadership and the leadership of your colleagues there at HRSA as we have been working on the dissemination and evaluation component of the Dissemination of Evidence-Informed Intervention Initiative. I'm Sally Bachman. I'm the director of the Center for Innovation in Social Work and Health, where this project is based at Boston University. I want to express my appreciation to my colleagues, Jane, Alexis, Marina, Clara, who are all in the room with me here for all the work that we are doing as a team to both follow the implementation of these interventions as well as evaluate implementation as well as some down the road outcomes. So I want to turn the webinar over now to my colleague Jane Fox, who has been really leading most of the work that's been going on here for this project, and she will introduce you to the rest of the team and then the plan for the webinar.
Thanks, Sally. Welcome, all of you. It's so exciting to see we have, I think, over 85 participants, almost 100. Wow, that's fantastic on our webinar today. As Sally said, my name is Jane Fox, and I am the co-PI of this initiative. We have several members on our DEC team, and I kind of want to do a quick shout out to everybody. This certainly, this type of project takes a lot of folks and a lot of brains to do, and I am so appreciative for our team. We have Serena Rajavian, who works with the Peer Linkage and Reengagement Group, Ellen Childs, who works with the Enhanced Patient Navigation Cohort, Alexis Marbach, as you heard earlier. She is here and she works with the integration of the buprenorphine cohort. You just heard from Sally Bachman. We also have Howard Cabral, who is a biostatistician. We have Claire Chen, who fantastically helps us with all of our data collection and storage and analysis. and Marina Sullivan, who is our research assistant. As I said, this intervention takes a lot of folks. We also have some intervention-specific experts that I want to do a quick shout out to. For the transitional care coordination, we have Allison Jordan and Jackie Cruzado Quinones, who I know are on the line since they gave us a big hello already. For the peer linkage and re-engagement and the enhanced patient navigation, we have the Janet Meyer and Janet Goldberg. And then for the integration of buprenorphine, we have Chinazo Cunningham and Paula Lum. All of these experts have had some sort of experience, most of them a lot, in the original versions of these interventions that April previously mentioned. So this is, as we mentioned, the Dissemination of Evidence-Informed Initiative. And the goal of this initiative is to replicate 4 previously implemented SPINS initiatives with the goal of creating care and treatment interventions at the end. We are hoping that these KDs, as we're lovingly calling them, will be able to be implemented in HIV care settings throughout the Ryan White HIV/AIDS provider network. So this is a multi-year initiative. It's led by both AIDS United and Boston University, and it represents really the first attempt to bring these SPIN-supported interventions up to scale across the field. So the 4 interventions being replicated, we have the transitional care coordination, which is a intervention of which we have 2 interventionists at sites who are working at both jails and in a community setting to link folks from jails to community care. We have a peer linkage and re-engagement of HIV-positive women of color. We have an intervention that is integrating buprenorphine treatment for opioid use disorder in HIV primary care, and an enhanced patient navigation, again, for HIV-positive women of color. As I mentioned, this is an initiative of which 2 sites have been funded to work together to do the work of the oversight, the creation of the adaptation of the interventions, to also fund sites, as well as provide technical assistance, and then also run a multi-site evaluation and dissemination. So AIDS United was funded as the Implementation and Technical Assistance Center. They were charged with selecting and funding 12 sites. So from 12 sites with 4 interventions, we have 3 sites per intervention. They also provide the technical assistance, and they coordinate the subject matter expertise for technical assistance and training on this initiative. Their team includes Alicia Downs, who is the Senior Program Manager, Hannah Bryant, who is the Program Manager, and Joseph Sewell, who is the Program Associate. I know Hannah is on the line, and I'm sure that Alicia and Joseph are as well. So hi, colleagues and friends. They too have hired intervention-specific experts. Those experts are Allison Jordan, again, and Jackie Cruzado for the transitional care coordination. For peer linkage and re-engagement, Simone Phillips and Latricia Miles. For patient navigation, Linda Scruggs and Vanessa Johnson. And for the integration of buprenorphine, Mike McVeigh and Kristen Myers. So the Dissemination and Evaluation Center, as we call DEC, was funded to Boston University, and we were charged with adapting and designing 4 intervention models for replication. We also have designed and are implementing a multi-site evaluation. For that evaluation, we're studying both patient outcomes as well as implementation findings. And then our goal, clearly moving forward, is to publish and disseminate final adaptive interventions and our study findings. So building towards implementation, this is actually a screenshot off of the Target Center. If you're interested in any of the 4 interventions that you are going to hear about, you can go to the Target Center and download any of these materials for each of these interventions. For each one, we have adapted intervention summaries, we have an implementation plan, and there is an implementation manual as well. So identifying and funding sites. We were asked specifically to work with AIDS United in finding sites to fund to implement these adapted interventions. AIDS United put together an online eligibility screening. We also did some additional background research on applicants that had applied that met the eligibility screening. We invited then all of those sites that were eligible to submit proposals. And then we hosted a meeting, actually AIDS United hosted a meeting, we attended at HRSA to review the proposals and to select sites based on geographic distribution as well as ability to implement the intervention. So sites include, locations of sites include Chester, Pennsylvania, Chicago, Illinois, Nashville, Tennessee, Atlanta, Georgia, Los Angeles, California, Newark, New Jersey, Chapel Hill and Wake County, North Carolina, Camden, New Jersey, Las Vegas, Nevada, Ponce, Puerto Rico, and Cleveland, Ohio. Oh, sorry, and Lexington, Kentucky. I almost forgot my friends in Lexington. So our goal really was, to the extent possible, to have a broad geographic distribution of performance sites to implement these interventions. So I'm going to turn it over to Alexis now, who is going to walk you through each of the interventions.
Great, thanks, Jane. So we've talked a little bit about each different intervention, and I want to make sure that everyone feels like they are properly oriented to the different interventions before we dive into some pre-implementation lessons learned and some data that we've collected. Marina just shared a link to the Target Center site where you can find out more information about these interventions. So if you want to dive into the implementation manuals and all of the background supporting materials, it's all available for you there. But the Transitional Care Coordination Initiative is intended for organizations considering strengthening connections between their jail health system and community settings for folks who are living with HIV who are recently released from jail. So the idea is to have these linkage coordinators who can help folks from when they interact with them in the jail setting all the way through linking to primary health care, HIV primary health care outside of the jail setting. The goal is to make sure that this client can meet with their HIV primary care provider within 90 days post-release. So as we go through some pre-implementation lessons learned, we'll be able to share how that's actually going down in each of the 3 sites that we're working in. But from the evaluation center perspective, we also want to make sure we included some enrollment targets. So the idea is to have at least 50 participants enrolled in the first 12 months of implementation and at least 20 enrolled in the following 6 months. And what you'll see from the evaluation enrollment numbers that we'll share in a little bit, our sites have far exceeded those targets. So the transitional care coordination sites are the University of North Carolina, Chapel Hill, Southern Nevada Health District, and Cooper Health System. So each one of these sites had a very different background, a different history working with their local jail, and have had a very different implementation path, even with this very strict implementation manual. So we'll share their variations on the model in just a moment. So the next intervention that we are looking at is peer linkage and re-engagement for women of color. So this is a short-term intervention designed to help folks who have not linked to care or fallen out of care engage with an HIV-positive peer. So the goal is to get someone into the clinic and then work with them for about 4 months and then transition them to a case manager or to the standard of care within the clinic. So again, looking for folks who have been newly diagnosed or have fallen out of care, the 4-month intervention, and our enrollment target was at least 70 participants enrolled in the first 12 months and 30 enrolled within the following 6 months of implementation. And our peer sites are range all across the country, as do all of our other interventions. We are working with Meharry Medical College in Nashville, Tennessee, which is one of the nation's oldest and largest historically African-American and Black academic health centers. Age Care Group in Chester, Pennsylvania, which for those of you who are unfamiliar with Pennsylvania geography, right outside of Philadelphia. Largest SQHC in southeastern Pennsylvania. And then Howard Brown Health Center in Chicago, Illinois. So many folks on the call may be familiar with Howard Brown Health Center's original location, and this is a new clinic on the south side of Chicago that opened about 2 years ago. So the next intervention that we're looking at is enhanced patient navigation for retention of women of color in HIV care. So this intervention is a little different than the peer intervention in that it uses trained patient navigators to work with patients for a bit of a longer time, so somewhere between 6 months and 12 months. And the patient navigators go beyond just helping folks arrange and attend HIV care visits, but they receive in-depth patient education sessions that they complete with the patient. All of those sessions are provided on a one-on-one basis and in person. So we're looking at women who are 18 years or older who have not been seen at the clinic in the prior 6 months or who have missed appointments in the prior 6 months, who are loosely engaged in care, who are not virally suppressed. As I mentioned earlier, these navigators work with their patients for a minimum of 6 months, suggested maximum of 12, and then they are rolled into the standard of care. We're hoping for about 70 participants enrolled in the first 12 months and then 30 enrolled in the following 6 months. Our patient navigation sites are Newark, Beth Israel in Newark, New Jersey, Grady Health System in Atlanta, Georgia, and the Keck School of Medicine at USC in Los Angeles. And then our fourth intervention is integrating buprenorphine treatment for opioid use disorder in HIV primary care settings. So these are primary care, HIV primary care settings that are taking on this new intervention. So it's working with a prescribing provider and then a backup prescribing provider and a clinical coordinator in the clinic setting. It follows the principles of harm reduction and enables providers to treat substance use disorder along with chronic medical conditions. So there's no predetermined time frame on this intervention, as we recognize that folks can stay on buprenorphine indefinitely, and as we will share in our pre-implementation lessons learned, we have noticed that folks are cycling in and out of the clinic as they have experienced relapse or have gone on and off their buprenorphine. So our sites are providing high-level quality care at all stages of someone's substance use disorder. We ask that folks, our 3 different sites, work with 25 participants in the first year and then additional 25 in the following 6 months of implementation. And that 25 number was initially set as when prescribing providers get a waiver to prescribe buprenorphine, there's a cap on the number of people that they can prescribe to each year. So our buprenorphine sites are the University of Kentucky or Bluegrass Care Clinic in Lexington, Metro Health in Cleveland, Ohio, and then the Centro Faith Clinic in Juana Diaz, Puerto Rico. So just a quick snapshot of where we are in terms of enrollment and where we will be in terms of enrollment. So enrollment started around November 7th, 2016, and enrollment will close November 1st, 2018. So you can see the sites at the bottom. In parentheses is a target number of patients that we're hoping that they'll work with before November 1st, and we'll explain some of the barriers and facilitators to enrollment as we walk through lessons learned. So, using an implementation science framework. I'm going to pass this back over to Jane to explain how we've designed our implementation science framework.
Thanks, Alexis. So as we mentioned earlier, we are doing two things with our multi-site evaluation. One is looking at some patient outcomes, but more importantly, HRSA was very interested in having us do an implementation science framework to determine if we could, and how feasible and practical it is, to take an existing interventions, adapt them, and then put them out for replication to others in the United States. So oops, look at that. How is it that they want to update always right in the middle of a webinar? Crisis averted. Update averted. So we chose the Proctor model and found that this really was a great model that would fit what we were looking to do. As you'll see, these are the components that we are looking at throughout the implementation period. They include acceptability, appropriateness, adoption, cost, feasibility, fidelity, and integration. So what we did was we took each one of those implementation outcomes and then built our data collection source to match. So we have several forms of data that we collect. Here you'll see we have matched each one to its respective implementation outcome. We did at the beginning, particularly around acceptability, we did some assessments and some pre-implementation qualitative interviews with staff to gauge their interest, to gauge buy-in, leadership buy-in in implementing at sites. And really to just ask the question, do you think this is going to work? And we received a lot of great information around that. We also included questions about appropriateness. Do you think that this intervention is appropriate for your clinic, is appropriate for the population that you're working with? Again, to figure out if providers, staff, and leadership really felt like this was a good fit. We also are looking and have been looking at adoption. We will be conducting a complete cost study. We have been across the board looking at feasibility, so both at startup, at implementation, and then maintenance. We've been looking at fidelity, and for us, one of the biggest pieces is this idea of integration. We really want to see that the intervention has become integrated as part of the standard of care at the clinic site. We gather a lot of the information for those last three things, feasibility, fidelity, and integration, off of site visit report forms. So we go out and we visit the sites annually. Through monthly site call forms, we have a call monthly with each one of the sites. And then we've also been doing some key informant qualitative interviews this summer. So what have we learned thus far? As I mentioned, this initiative is a 5-year initiative. It was funded in 2015. So as of in a couple days, September 1st, we'll be starting year 4 of this 5-year project. And in the next few slides, Alexis and I will be sharing implementation lessons learned so far. So we'll start with transitional care coordination. Through the calls, the site visits, the qualitative interviews, as well as the initial assessments that we conducted, these are the things that really rose to the top. Sites with strong implementation teams and leadership have really been able to smoothly weather staff turnover and transitions. We know and we fully expected that we would encounter staff turnover and transitions. It's kind of just the nature of the work that we do. So those sites really were able to work through that, to have quick and timely coverage plans when staff were turning over, as well as hiring rather quickly when those turnover situations occurred. This intervention in particular requires a lot of tending to the relationships with partners and particularly with the jail. Administration, medical staff, and officers in the jail, they all have opinions about this intervention, and they all can help or hinder the success of this intervention. In addition, staff turnover within the jail setting could also impact the intervention staff. The better relationship the interventionists have been able to build with administration, medical staff, and officers, the easier it is when staff turnover within the jail setting happens. Adaptations have been necessary to fit this model into each one of the settings. So for each one of these sites, it's been very interesting to think about what the model brings to it and what are the tweaks that need to happen. For example, one of the sites that has been funded in Las Vegas, Nevada, is quite a bit away from the jail, as well as they don't have their own clinic where clients would come post-release. So their interventionists are actually working with multiple clinics out in the community to make sure that those appointments are made and reached by those clients that are released from jail. In contrast, the clinic in Cooper Clinic, which is actually in Camden, New Jersey, they're 2-3 blocks right down the road from jail, and all of the clients, for the most part, know Cooper and know that when they're released, they can go right down the road to get into their appointment. So post-release challenges are many. Clearly, addressing them is the key to retaining clients in care. And it's not just addressing them post-release, but addressing them and creating a plan pre-release. These challenges typically include homelessness or unstable housing. There are a lot of issues around substance use disorders and mental health disorders, transportation, as well as ongoing engagement with the criminal justice system. The next intervention, peer linkage and re-engagement. The implementation lessons that we have been able to glean from the 3 sites thus far, one, and I think we're going to kind of see this across the board, is each one of these really needs to have some strong clinic leadership. And particularly for this intervention, it was having an internal champion who was necessary for the initial launch, as well as navigating potential challenges in implementation. And some of these include, and you'll see below, hiring and onboarding of peers. For many sites, it is difficult to go through an HR process to hire peers for several reasons. The peer job description doesn't always fit within what HR job descriptions are, particularly in a clinical setting. There are also issues of education level that HRs tend to be a little bit stringent around, as well as requirements that don't necessarily fit the hiring of peers. And so it requires someone in a leadership position to really champion working with HR systems. Case management needs to be in place prior to implementation. It has never been the intent of this intervention to replace case management. This truly is an enhancement to case management and to help find women of color who have not linked or who have fallen out of care and bring them back in, and also provide some of that supportive work for them while they're linking back into the standard of care case management system. And both peers and data managers need to have space that is private, confidential, so that they can have conversations with clients. We recognize that many sites across the US are really squished for space, but for this work to happen, it is very important to have some quiet, private space for conversations with clients. I'm going to pass it off to Alexis, who will talk. Oh, wait, we have more. We have, oh, that's right, the additional peer linkage and re-engagement lessons learned. So the other three things that we have found really interesting is this idea of mobility outside of the clinic. This is an intervention that does not work well while you're just sitting at your desk. If clients were easy to link and re-engage, they wouldn't be eligible for this, this intervention. And many of them need to be able to meet with interventionists outside of the clinic. This has been something that we have seen across the board with the 3 sites as a key to success. Transportation assistance is crucial to help clients get to appointments and to the meetings with their peers. And I think transportation is something that we see as a need with all of the clients in the study, and you'll see that when we talk about some of the data later on. And then finally, clear, consistent communication between team members and the larger clinic is crucial to working with women who are at risk for falling out of care or who have struggled to link. We've really promoted this idea of having an integrated model into your clinic care setting. This requires that everyone has a voice at the table, that peers can come and speak with the clinicians about conversations that they may have had with clients, about why they haven't linked, and do some of that group think around how can we best serve these clients. Now I will pass it off to Alexis to talk about enhanced patient navigation lessons learned.
And everyone, just before we switch between the 2 interventions, I want to remind you that we have the text chat going. So we have some really awesome staff members from the projects that we're talking about joining us today. And we have the great team from AIDS United, the ITAC, who can also answer questions. But we're interested to hear if you're implementing similar interventions, if you're using similar strategies to evaluate. So please do let us know. So I'll give you an update on where we are with enhanced patient navigation. So one of the things that we've learned is that co-located services are really important. So our Grady team has everything in one building. So you go into Grady for your HIV primary care visit, you can be guaranteed that the data manager is going to catch you in the elevator, and then the nurse who you've been trying to avoid is also going to see you in the hall. So everybody is right there, which makes it easy for the patient navigators to help patients get to where they need to go, and then also to interact with patients, even in just, you know, a friendly manner around the clinic, so the clinic feels a little bit more like home. At USC Keck, our patient navigators are doing a great job running between buildings. It's a large campus, but they are trying to get patients at all different points around campus, and it can be challenging just to naturally intersect with their clients to do any relationship building or to help them navigate towards appointments. So we found that co-located services are definitely helpful. Onboarding and hiring of patient navigators is key to success. I mean, you could really say this across any of the interventions, that proper onboarding and welcoming folks onto your clinical team makes everything more efficient and effective. But the patient navigators in some clinics that we've worked in, over the years, have not been integrated as team members into the clinical team. They're seen as maybe volunteers or, staff that's not connected to the clinical team. But if patient navigators have access to the EMR, if they're involved in the morning huddles, their patient notes are elevated within that EMR system, and providers often respond to their messages a little bit faster and just improved overall coordination of care. We're also going to be heading to APHA in 2 months to talk about tending to professional development of patient navigators. We are very cognizant that this is a time-sensitive or time-limited project. And so we want the patient navigators and all of our clinical staff across all projects to take the training and the lessons that they've learned by working on these projects and take the next step in their career, whether it's at the clinic or at another HIV care service clinic or service organization. Patient navigators have told us that it takes them a lot of time to build trust between them and the client. So, you don't just launch right in with patient education sessions and just go education session, education session, education session, and done. It takes time for people to feel comfortable sitting with each other for an hour or so, or talking about some of the personal information that comes up in these education sessions. Patients with high acuity need to have basic needs addressed prior to initiating the patient education session. So we use an acuity tool at the start of the intervention, and then when a patient is getting close to transitioning to the standard of care. And our patient navigators have told us that they really need to deal with the immediate needs that a client is presenting with prior to rolling into an education session, which means that they need to be flexible with their timelines, and also establish healthy boundaries when engaging with patients so that they can keep that professional boundary and be the most helpful that they can be to the patient. Okay, so looking at our implementation of the buprenorphine initiative. And I know that we have some of our buprenorphine team on the text chat. So please do ask some questions, and buprenorphine team, please do weigh in with your experience. And we also have Pamela Belton, who is the project officer who's working on buprenorphine initiative. So feel free to ask questions to her, and Pamela, please share with us too. So as we were getting going and we were asking what does enrollment look like? What should it look like? We thought you should really be able to, due to the epidemic, the overwhelming need for services, be able to work with 25 patients each year as per the restrictions on the buprenorphine waiver. And what our great team of providers and clinical coordinators have told us is that working with patients with high acuity and substance use disorder need more time with clinic staff. They don't have a linear path to recovery, so they come into the clinic more frequently. They may initiate on buprenorphine, go through the induction process. They may stabilize for a while, then they may relapse, go back through induction. And while this is the path of working with folks who have substance use disorder, it is not the linear path that you might think when you take the buprenorphine waiver training. That makes it sound like, hey, induce someone, stabilize them, maintain them, and that's it. So our clinic staff has told us that it does take a lot more time, so they aren't able to enroll as many people in order to keep the high quality of services for the patients who come in. This is also something that's important to keep in mind if you are thinking about implementing a buprenorphine initiative in your clinic setting, that folks will come back in much more frequently than they do just for HIV primary care. So that involves working with your front desk staff, your scheduling staff, and making sure that there's space in the calendar or the clinic schedule for folks to come in more frequently. Another implementation lesson learned is that the landscape of MAT, so medication-assisted treatment, is evolving. So just even as we wrote this manual, We sent it off to the teams, and 3 months later, an injectable form of buprenorphine was available that wasn't even on the market when we had conceptualized this intervention. So it's important for sites to have a champion or advocate and make sure that they are at the table for conversations about substance use disorder and treatment within their local and clinic area. So what does it mean to be at the table? It means to have a pulse on the state and local regulations that could impact your implementation. So even in the time that we have rolled out this manual, now nurse practitioners and physician's assistants can be waivered to prescribe, but each state has a different way that they regulate that. So we need each local clinic to be at the table with other folks who are having conversations about MAT to stay on top of local regulations. Sites need to be able to have access to multiple forms of MAT. Buprenorphine isn't for everybody. It's not the right course of treatment for every person with opioid use disorder. So sites need to have other colleagues and team members that they can help refer out to for other forms of MAT. And we know that some of the patients who are enrolled in our project, all of which are people living with HIV, have partners, friends, family members who are not living with HIV and don't have the same access to buprenorphine treatment services. So we've learned that our clinical coordinators and prescribing providers have had conversations about diversion and about sharing medication so that our patients can stay on their healthiest path. So providers and clinical coordinators are addressing patients with high acuity, co-occurring substance use disorders, mental health concerns, and high levels of experienced stigma, impacting the level of care that they need to receive, which I think we touched on in the last slide. But the co-occurring substance use disorder is something that we've seen in each one of the clinic sites that we are implementing in, and each one has a different primary co-occurring substance use disorder. So it is very regional. So that can also be another reason to partner with your local experts who can help you navigate opioid use and substance use disorder trends within your community. So another thing that we didn't do that we really should have done is make a whole manual dedicated to our star, the clinical coordinator. I'm looking at Jen right now if we were on some kind of video conference, if you could see us. Our clinical coordinators are amazing. We call them the glue person of this intervention. They are the person who sits with the client who in the process of getting induced all the way through every part of their treatment process, works with them to get anything from a housing referral to employment to getting any need met, and they also provide a lot of emotional support throughout this process. So we are in the process of working with Kristen Myers, who's on the buprenorphine training team for the ITAC, to develop a clinical coordinator manual. Another thing that we've heard from other clinic providers across the country is that implementing this project without a clinical coordinator is just not feasible. So we want to make sure we lift up that role. So other barriers to implementation include the stigma of accessing substance use treatment in smaller communities, geographic barriers, especially in I was going to say especially in, and then try and list off our sites, but each one of them has a different geographic barrier that they're working with. But it can be hard for folks even just to get to the clinic to get the treatment that they need. And then with the buprenorphine film, you have to come back in more frequently to get your treatment. So folks aren't just coming in one time and then not coming back for 6 months. And then issues with insurance and prior authorization. All right, so now we're going to talk about some of the data that we've collected through our encounter forms. So for each one of these interventions, we have asked interventionists to
record their daily encounters with the study clients. This includes the attempts to contact the client, the actual contacts with the client, and contacts that were conducted on behalf of a client. For example, they coordinated with a case manager to identify apartments that a client would be eligible for to go look at. So this is our encounter data numbers as of a couple weeks ago, the 14th. We have had over 13,000 encounter forms entered. And as Alexis said, our enrollment still has yet to close. So our interventionists are doing incredible work, as well as documenting all of this work for us, which we are eternally grateful for. You will see they're broken out into their groups. The first three are the transitional care coordinators. The next three are the peer intervention group. The next three, enhanced patient navigation, and the bottom three are the integration of buprenorphine. So we have collected data, as you've seen, and for each one of those, we ask, what did you do with the client today? And of course, we tried to be as comprehensive as possible. Still, we tend to get some write-ins under other, but these are the top reported encounters by cohort. So you'll see kind of across the board relationship building. We have done this type of methodology on a few studies before, and we didn't include relationship building, and that is something that continually was checked off as an other and written in. So we have now included it, and it really is one of our top reported encounters with all four of these interventions. For transitional care coordination, it also includes discussing medical appointments with clients, providing appointment reminders, finding clients and conducting outreach, and then following up with providers to discuss the client issues. As you'll see with peer linkage and re-engagement, it's really the same top 5 reported encounters that they conduct with the women of color who have not linked or who have fallen out of care. When we look at enhanced patient navigation, again, relationship building, providing appointment reminders, following up with providers to discuss clients, finding clients and conducting outreach, and then discussing medical appointments with clients. And then integration of buprenorphine is a wee bit different than the previous 3. Those top reported encounters include conducting a monitoring appointment. As Alexis said, clients in this cohort tend to come in more frequently than they do with the other 3 groups. And there is this component of monitoring buprenorphine treatment. They provide client support during maintenance or stabilization, relationship building. They assist with obtaining transportation services, and they provide coaching on living skills. So I'm going to turn it back over to Alexis to start talking about our patient outcomes.
Great, thanks, Jane. And as we are setting up to talk about patient outcomes, I do want to remind folks that our team member Clara is here. Clara is the rock of our team. She is in charge of all of the data management and quantitative data collection tools. So if you have any questions as we're going through this, please do ask in the text chat. So we know that implementation science it's our focus, and it's the main approach that we're using, but we don't want to neglect to look at patient outcomes, right? So if we're implementing with fidelity to the model and everything's going according to plan, but no one's actually having improved health outcomes, then that's also a problem. So we're looking beyond viral suppression here. We're looking at patient satisfaction. We're looking at changes in patient experience, factors that support patient success, and we're trying to understand these issues as they relate to our replication efforts on our path, again, to creating those care and treatment interventions, or the KDs that Jane mentioned earlier. So each one of these interventions has a little bit of a different timeline in terms of when people receive follow-up interviews, and that's partially due to when they interact with their various intervention staff members. So for example, peer linkage and re-engagement, we want to follow up with people right around that point where they might be transitioned to the standard of care. So 3 months, so that's right before they transition to the standard of care, and then 6 months, which is about 2 months after they transition. Our enhanced patient navigation group, we want to follow them from the 6 months, 12, and 18 months, so that we can look at them right around, again, all of those points where they would be transitioning. Integration of buprenorphine treatment into HIV primary care. These patients do not transition to the standard of care necessarily, but so we're following the 6, 12, and 18 months. And then transitional care coordination, we're looking at 30 days post-release, and then 4 months post-release. And that post-release date is their index incarceration. So even if they are re-incarcerated, we're looking just from that first index incarceration and then their index release date. So we have the baseline, the follow-up, and then we have medical chart abstractions. We've developed a chart abstraction tool, and our fabulous team of data managers across the country use this tool to go through their EMRs. And for those of you who work in EMRs, you know that that is no small ask. To go through the various different EMRs, paper systems, online systems, to give us chart abstraction data at 6 months, 12 months, and 18 months, so we can look at health outcomes and viral suppression. So we have some baseline survey data that we'd like to share with you, and this is all as of August 14th. And just as a reminder, we're not going to be sharing follow-up data at this point because enrollment has not closed and follow-up data collection has not closed. So we don't want to influence the outcomes of our data collection or our intervention. But stay tuned. We will have more for you this coming year. So we'll run through some of the baseline survey demographic points first. So just the abbreviations at the top, TCC, again, is that transitional care coordination. Peers is peer linkage and re-engagement. PN will be enhanced patient navigation. And BUP is for integration of buprenorphine into HIV primary care. So in terms of age, it looks like our patient population ranges from about 39 to 44. We asked folks to identify the gender that they currently consider themselves to identify with. And you'll notice for peers and patient navigation that there's no one who currently identifies as being male. Both of those are for people who currently identify as being female. So more males, again, in the transitional care coordination intervention and in the buprenorphine intervention. In terms of race, we asked participants to tell us the race that they identify with. And you'll notice the double asterisk at the bottom. Participants were asked about each category separately. But for transitional care coordination, peers, and patient navigation, the majority of participants identified as Black or African American. In buprenorphine, the majority of participants identified as being white. And then next we have multiracial, American Indian, Alaska Native, Asian, and then unknown or refused. We asked participants if they identified as being Hispanic, Latino, or Spanish origin. In the transitional care coordination intervention, The majority of participants said no, and the same was true across the other 3 interventions, and we only had 2 that refused. We asked participants what language you speak most of the time with friends and family. And again, I should have said this earlier, but the actual value is in the table, and then in the parentheses are the percentage of total. So the majority of our participants said that they spoke English most of the time at home with friends or family, and then next was Spanish. In the patient navigation and the peer group, we had quite a few participants who identified as speaking another language. I know that at AIDS Care Group in Chester, Pennsylvania, they have a number of participants who speak different African dialects, and that's contributed to this as well. So in the other, some folks did identify the language that they speak, so it'll be interesting to share back the various other languages as well. Highest level of education greater than a high school diploma or a GED. The majority of participants across the board said that they did not have education greater than a high school diploma or a GED. And then we have this broken down by some college, 4 years of college, master's degree, so we'll be able to share more information about the specific levels of education when we do our full data analysis. I'll turn it over to Jane to talk about basic necessities and other needs.
So we asked, during the last 12 months, how many times did you run out of money for basic necessities like housing or food? In the transitional care coordination, 30% reported daily, followed by 20% who reported weekly, and another 20% who reported monthly. For the peer intervention with women of color, 38% reported monthly. For the patient navigation intervention, almost 40% reported never, followed by 35% who reported monthly. And then for the buprenorphine intervention, about almost 30% reported weekly, followed by almost 25% monthly and 25% never. We ask about health insurance, and certainly this is an interesting time to learn about people's health insurance. The majority of folks reported having Medicaid. And interestingly, on the buprenorphine, over 35% reported having a plan through their state marketplace. And certainly this is a result of the sites that were funded, the geographic locations. Where do you live now? Now, for folks that were incarcerated, the TCC intervention, we asked the question, where did you live prior to incarceration? The majority of study clients live in a home that they own or rent, followed by living in someone else's home or apartment. Interestingly, those are swapped in the TCC intervention. About 43% reported living in someone else's home or apartment, and 28% reported living in their own home or apartment that they own or rent. We ask about taking HIV medication. Clearly, as you've heard, one of the overarching goals of this intervention is to retain patients in HIV care and increase rates of viral suppression. That requires taking medication. So you'll see the majority of study clients are currently taking HIV medication. The TCC rate is lower than the others because, as we've mentioned, the baseline interview is conducted while they're in jail. And often the client does not immediately have access to his or her HIV medications. This is a component of that intervention, so reducing the time of which someone is in jail without medications is a goal of that specific intervention. We ask about substance use treatment in both, or actually all three, the TCC, the peers, and the patient navigation. The majority of clients reported not participating in substance use treatment in the past 3 months. However, in the buprenorphine intervention, we see that about 50% of those clients who answered the question reported that they had participated in some type of substance use treatment in the previous 3 months before baseline. So we ask a lot about reported needs in both the baselines and the follow-up. We hope that looking at these needs at baseline and at the follow-up points, we'll be able to determine what needs are being met while folks are participating in the interventions. So when we look at transitional care coordination, the top needs are transportation assistance, housing assistance, assistance in applying for benefits, medication assistance, and assistance getting substance use treatment and or mental health treatment counseling. When we move on to the peer linkage and re-engagement, we see, again, transportation and housing are number 1 and number 2, and number 3 being assistance in applying for benefits. Assistance in getting substance use treatment and or mental health treatment counseling, and then we also had a few write-ins on the other. Enhanced patient navigation, those top reported needs are, again, transportation assistance and housing assistance, applying for benefits, medication assistance, and assistance in getting substance use treatment and or mental health counseling. And then for the integration of buprenorphine, transportation assistance, assistance in getting substance use treatment and or mental health, housing assistance, medication assistance, and assistance in getting medical care. I think it's fascinating that here we have 4 separate cohorts, yet the needs really are the same when we look at all 4 of these cohorts. I think that it is indicative probably of the larger needs of the HIV community as well here in the US. I'm going to pass this on to Alexis to talk about next steps.
Great, thanks, Jane. So again, if you have any questions, feel free to let us know in the text chat. Jane, Marina, Clara, and I are all standing by, as are our other team members across the country. So I just want to give you a little orientation to where we are in terms of next steps. So the Dissemination of Evidence-Informed Interventions, Dissemination and Evaluation Center, so the DEC team, we have 2 more years of funding on this project. So we are smack dab in the middle of data collection, and so this year will be a big year for wrapping up data collection and for wrapping up our work with our site. So first, we are conducting key informant interviews with team members at each intervention site. So each DEC team member has been assigned between 10 and 20 interviews to conduct over the phone, and we'll be conducting a qualitative analysis on those. And if all of our data managers were here, they would say in unison that November 1st, 2018 is the last day to enroll. Our intervention team members will still be able to work with our clients all the way through the last bit of this intervention, but we won't be enrolling new folks into the multi-site evaluation. Can new folks at each site still be initiated into the intervention and initiate intervention services? Yes. They just won't be part of the multi-site evaluation. December 2018, we hope we'll see many of you at the Ryan White conference. We'll be providing project updates from each of the interventions and from our data collection and data analysis. April 30th, 2019 is the last day to enter data. So any chart abstractions, any follow-up data, any baselines, it's all got to be in. We'll close data collection and we'll begin to start running some analyses on that and doing data cleaning and site closeout, because at the end of, I'm going to look over the internet to my colleague Hannah, that it's in July, that's when our sites will end their funding on this initiative. So our team members at the ITAC will be working with sites this year and through July on sustainability, replication, integration plans to help sites integrate this into their clinic setting so that they can keep providing these amazing services past July 31st. And then by this time in 2020, the DEC team will create final versions of the care and treatment interventions. So you'll be able to go onto the Target Center site and pull down a manual that has all of the intervention materials, site spotlights from intervention teams, toolkits, tip sheets, checklists, all of the things that you would need to use to download the materials and implement this in your community. So Marina shared earlier the link to the next level targethiv.org site, but here you can go now to see everything from logic models to staffing plans to the adapted intervention summaries that were created for each intervention that has a lit review, talks about the theory of change that we're using, and provides contact information for all DEC and ITAC team members. And you can go there now, and you can go there throughout the intervention. And if you go to download a material and it says, please enter in your name and email address, it's not because we want to spam you, it's because we want to be able to send you a note when the final intervention manuals go live. So feel free to enter in your information there. And with that, I'll leave up our contact information so that you can reach out to us if you have any specific questions for any team member. Again, my name is Alexis Marbach. I am the program manager on the intervention as well. So I'm happy to be the middle person to help get you to the right person on the team to ask a question. You can also email me if you're looking to reach out to the ITAC. I can put you in touch with them. So yeah, happy to do that. So now, we'd just like to, I would say open the floor, but it's really open the text chat to questions. If you have any questions for us, please feel free to type in and we can go through them one by one. Corliss or April, I didn't know if you had any things you wanted to share or closing comments. And I know that I'm putting you on the spot and you've probably muted yourself. But if you have anything that you'd like to share, feel free to unmute as well.
Hi, Alexis. This is April. No, this has been great. Thank you so much. And I'm really looking forward to hearing any questions from the participants on the webinar.
Me too, April. I know it's like a lot of pressure. People are typing. It's like I can see the little like someone is typing blurb coming up. But we did have a question come in while the webinar was going on about will we be sending out slides. And again, we will be sending out a link to the recording, and we'll be able to post the slides in that same place on the next level targethiv.org site. Yeah, thanks, Jane. So you can go there. And it takes, from what we understand, about 2 to 3 weeks to get everything live on the site. So stay tuned. So we'll give people just another minute to ask questions if they have them. Or I'll look through the internet also to Hannah, my colleague at AU, to see if there's anything that we forgot. So Jason, who is one of our team members at Metro Health on the integration of buprenorphine project, asked, will needs identified by clients be shared in other capacities? So Jane and I are looking at each other. Jason, can you type in a little bit more about what kind of needs you're looking at? Are you looking at needs from other interventions? Or will people be able to see more specific needs when we do final data analysis? We'll wait for Jason to type in. Oh, the needs collected during interviews. Yes, so everything that we collect during a baseline interview and everything that we collect in the follow-up interview, we will be analyzing. And we will be doing more of that in the winter, starting December, so after everything, all of the baseline is closed. And we'll be doing that until we analyze a final follow-up interview. So we'll be able to share all of the needs that are reported across all interventions and all of the needs that have changed. We'll be able to see change over time as well. Okay, so it doesn't look like there are any other questions at this point, but I'll just ask Jane to forward again to the email addresses. So what we'll do is we'll wrap up the interview. We've all been conducting so many key informed interviews. We'll wrap up the webinar, but we'll leave this slide up for a moment. So if you want to write down our email addresses and send us any follow-up questions, we'll be happy to answer them. But we really appreciate your time and your participation and your interest in this, and we hope that the tools that we design are useful to you and your work moving forward. And if you have any feedback on things that you would like to see from this intervention or this initiative, tools that would be helpful in the field, please do let us know, and we will integrate that into the way we think about our final toolkit. So we hope everyone has a really wonderful rest of their afternoon, and we look forward to continuing this conversation in the future.
Thank
Thanks, everyone.
Thank you.